I'm Dr. Everton Prosper. I am one of the co-directors of the HRSA Bridge program. I'm also an assistant professor of medicine here at SUNY Downstate, the SUNY Downstate Health Sciences University, and I'm also the director of the Geriatric Medicine Fellowship. It is my honor to do this presentation today. It is a brief overview of geriatric medicine. This is one of my favorite collages. It says a lot about elderly patients and the different dimensions. For this talk, I have no significant financial disclosures or any significant conflicts of interest. However, this talk is supported by a grant from the HRSA, the Health Resources and Services Administration of the U.S. Department of Health and Human Services. Okay, so for our objectives, by the end of this talk, we or the learners should be able to define geriatrics or geriatric medicine. The learner should also be able to discuss age and statistics nationally, that's in the US, and internationally, identify some key features of geriatric medicine and general principles of aging, identify principles of the geriatric assessment, briefly discuss some financing, coverage, and cost of healthcare in the elderly, and identify 4 of the guiding principles used in medical ethics. So I would like for us to brainstorm for a minute and just to think about, you know, what is aging? What is aging? And this is a clear-cut definition. Aging is the progressive decline and deterioration of functional properties at a cellular level, at a tissue level, and at an organ level, leading to a loss of homeostasis, a decrease in the body's ability to adapt to internal stimuli, and an increased susceptibility or an increased vulnerability to disease and mortality. And this is all part of the normal aging process. This is all part of normal aging. Now, this might sound a little simplistic or obvious, but aging is inevitable, meaning if you live long enough, you will get old. There are a lot of theories to explain why the human body gets old. There are a lot of theories to explain why the maximum human lifespan is about 120 years. But irrespective of the theories, irrespective of the mechanism or the physiologic explanation, there's clear-cut consensus that the buildup or the accumulation of injury and the accumulation of insults and repeated exposure to a variety of stimuli, they all lead to more and more damage and more burnout at the cellular level, at the tissue level, and at the organ level. And irrespective of the explanation, there are a variety of theories. It's been implicated that there is DNA damage, targeted DNA damage, mitochondrial damage, free radicals injury, and an inability of the body to repair those injuries. There's a hormonal mechanism, an immunological mechanism, but irrespective of the explanation, there is a consensus that cells have a limited ability to divide, and they have a limited ability to repair. And so over time, they become burnt out. And in a similar way, the insults and the injury leads to diminished reserves in our organs. I want you to think about this for a minute. What are some of the visible signs of aging? And Dr. Reinhardt touched on this last week in detail. But what are some of the visible signs of aging? Some of the physical manifestation of aging, you look at an older person, you may notice maybe some hair loss, or changing in the color of the hair, changes in the pigmentation of the hair, decrease in height over time. decrease in lean muscle mass, skeletal muscle mass, decrease in bone mass, wrinkles and thinning skin. Those are some external visible changes. And then there's some internal changes. As we get older, there may be a redistribution of the body fat and an increase in belly fat content, intra-abdominal fat stores, a decrease in reserves in the organs, particularly a decrease in the kidney function, and there may be changes in the volume of distribution. And this has implications. It has clinical implications because it affects and it impacts, you know, our decision making. It impacts our prescribing habits, medication prescribing habits. Another question, I want us to brainstorm again. Is there a difference between geriatric and the younger adult medicine? Is there a difference between geriatrics, which is medicine in the older adult, and the younger adults medicine? And the short answer to that is yes, right? The short answer to that is yes. Otherwise, there wouldn't be a need for this field. But in order for us to adequately answer that question, I think we need to define geriatrics. Geriatrics or geriatric medicine is a branch of medicine that focuses on healthcare of the elderly. It focuses on healthcare in older adults. And it also focuses on the impact of certain specific factors, the impact of cognitive, the impact of psychological factors, the impact of biological factors, and the impact of cultural factors on the health of older adults. The word geriatric has an origin in Greek. The first part of the word is geros, meaning old age. The second part is iatros, means healer. So in essence, it is healer of the old aged or healer of the older adult. Geriatric medicine can be used interchangeably with the term medical gerontology. Gerontology is simply the study of the aging process. But medical gerontology is the equivalent of geriatric medicine, which is a field of medicine or a branch of medicine that specializes, that deals with the care of the older adult. In geriatrics or geriatric medicine, we put a lot of emphasis on care of the older adult, and we seek to utilize a multidisciplinary team-based approach. The healthcare team usually consists of, but it's not limited to, it consists of the PCP, the primary care physician, the specialist, the geriatric psychiatrist, the NP, the PA, nursing, the pharmacist. All of these individuals play an integral role in the care of the patient. We should not overlook the importance of and the role of the family and the caregivers in the care of these patients. In geriatric medicine, there's emphasis placed specifically on health promotion, an emphasis on addressing the unique and complex needs of this subset of the population. This includes incorporating this factors such as respecting patients' autonomy, prevention of diseases, diagnosis and treatment of diseases, limiting disability and dependency, and promoting health and well-being, promoting and maintaining independent function. And all of this is consistent with the core mission of the American Geriatric Society, which states, and I quote, to improve health, independence, and quality of life of older adults. So is there a difference between geriatric medicine and younger adult medicine? And again, the answer is, so what is the difference? Geriatric medicine differs from standard adult medicine or younger adult medicine because it focuses on the unique and complex needs of the older adult. As mentioned previously, the aging body is physiologically different from the younger adult body. So the needs are different. And so at times the plan of care and the interventions may be different. Okay, senescence is a non-pathological decline in functional reserves of organs. And this you see in the aging adult's body. There may be age-associated weakening of our defense system, which predisposes us to certain illnesses and certain diseases, which predisposes us to certain complications. There's an increased susceptibility to certain harmful agents. Okay, and there's a predisposition to specific geriatric syndromes. Take a look at this cartoon. I want you to consider what the question is that's being answered. There's a question that's being asked and it's being answered. What is the question? What could the question be? The bottom reads, coming in for your prescription and buying a ton of other stuff you really don't need. Coming in for your prescription and buying a ton of other stuff you really don't need. That's one of the side effects. So what could the question be? What is the side effect of being old? Now, that is a weird question. What is the side effect of being old? Why phrase it that way? Why side effect? A side effect is a secondary, usually an undesired or an undesirable effect of a drug maybe, or of a treatment plan, of an intervention. So why would someone ask the question, what is the side effect of being old? Boom. Throughout our talks and throughout these series of talks, you're going to see this stop sign, this symbol. And this is our effort to educate and to prevent or to limit or to minimize ageism. Ageism is stereotyping, ageism is prejudice, ageism is stereotyping or prejudice and or discrimination against individuals or a subgroup of individuals based solely on age. And in the context of this talk, it's stereotyping, prejudice, and discrimination based on older age. We want to stop, we want to prevent, we want to minimize ageism, because ageism is dangerous and it can have harmful outcomes. I highlighted three points here. One, association does not imply causation. Association does not imply causation. And what do I mean by that? Because old age is associated with certain diseases, it does not mean that old age is the cause of those diseases. Because old age may be associated with certain illnesses, it does not mean that old age causes those illnesses. Two, increased frequency is not synonymous with normal or pathological. Increased frequency is not synonymous with normal or pathological. And what do I mean by that? There might be certain diseases, certain illnesses may occur at a higher frequency in old age, but it doesn't mean that it is normal for the older adult to have certain diseases. Okay, and it is important to not stereotype. It is important to not be prejudiced. It's important to not discriminate based on age, because it impacts our assessment and it impacts our decision making and it impacts health outcomes. Case in point, let me give you an example. You may have an older adult who presents with a limp, right? An older adult who presents with an abnormal gait. Now, if the assumption is made that that older adult has a limp or has an abnormal gait because the older adult is old, then that assumption may steer the provider away from pursuing, a workup from ordering the appropriate diagnostic tests. And so that's a problem, because an abnormal gait may be as a result of an underlying medical problem, which is potentially treatable and potentially curable. And so a patient who presents with an abnormality, if certain assumptions are made based on stereotyping, based on prejudice, based on discrimination, and the appropriate attention is not given to that presentation, you know, the patient may be deprived of well-needed medical care, appropriate care. So ageism is bad. We want to stop ageism. Okay, we want to educate on this topic. And that leads us to a very important, this very important slide. Okay, this slide speaks of the, it has to do with being age friendly. Okay, every adult, every older adult is entitled to comprehensive geriatric care. Now, we can debate whether or not health care is a right. We can debate whether or not it's a market good. But the bottom line is that every older adult is deserving of comprehensive geriatric care. And one of the best models to ensure that an older adult is receiving comprehensive geriatric care or age-friendly care is to operate under the 4Ms model or the 4Ms framework. And the 4Ms framework puts emphasis on what matters to the patient, aligning our goals of care with the patient's preferences, the patient's goals. Okay, it puts emphasis on medication with the understanding that it is good to limit prescribing, with the understanding that if we have to prescribe medication, to use age-friendly medications that will not necessarily interfere with what matters to the patient, that will not impact the patient's ability to maneuver, to move, and to perform activities of daily living and things like that. The age-friendly model puts emphasis on mentation, okay, efforts towards preventing, identifying, treating, and managing depression, dementia, delirium. And it puts a lot of emphasis on ensuring, you know, maintaining mobility and ensuring as much as possible that the patient can maintain independent function. Is old age a determinant of health? Is aging synonymous with disease? We're brainstorming again. Is old age a determinant of health? Is aging synonymous with disease? What are determinants of health? A determinant of health is a factor, or determinants of health are factors that influence the health of individuals, right? It influences the health of individuals, influences the health of populations. At any age, health may be determined by a complex interaction between biological, behavioral, social, economic, and or environmental variables. So these factors, these variables don't exist in isolation. There are four overarching or four key categories of determinants of health. They are 1, genetic; 2, nutrition; 3, lifestyle; and 4, environmental. And again, they don't exist in isolation, but they all interrelate. Older adults are susceptible, or they have increased vulnerability to certain underlying medical problems. An older adult presenting with an acute illness may have vague, non-specific signs and symptoms. For example, an older adult presenting with a UTI, urinary tract infection, may present with a mild fever. A mild fever. The clinical situation may progress to confusion. It may predispose the patient to falling. The patient may fall, fracture a hip, develop a DVT, PE, and subsequently die. A younger person with an acute case of gastroenteritis that case of gastroenteritis might be self-limiting. Patient may have no complication, a younger patient. But in an older adult with gastroenteritis, that same presentation, it can lead to dehydration. It can lead to dizziness and confusion, tachycardia, rapid heart rate. Can lead to falls, fractures, blood clot, and subsequently death. Polypharmacy, drug-drug interaction, adverse reactions. Functional decline may be different in the older adult. It would impact things like activities of daily living. I'll get into that a little later on. It may impact quality of life and life expectancy. So is old age a determinant of health? Aging is not synonymous with disease. And I want to reemphasize that. I'm reemphasizing that point. Aging is not synonymous with disease. Aging is a process. Diseases have causes, they have underlying causes. Senescence or normal biological aging usually has a good impact, a positive impact on quality of life and life expectancy. Diseases are more like pathological aging. They're age-associated diseases, and those things have a negative impact on quality of life and life expectancy. Many older adults are vibrant, they're energetic, they're healthy, and they live normal lives despite the fact that they have advanced age. So while certain diseases may be more prevalent in the elderly, aging is not synonymous with disease. And age in and of itself is not a principal determinant of health. There's normal healthy aging, as mentioned, and there's pathological aging. Normal healthy aging, also called biological aging, is a natural process that usually has a positive impact on quality of life and life expectancy. Age-associated diseases are a manifestation of an underlying problem, of an abnormal aging process with underlying triggers, underlying causes, and therefore it's considered pathological aging. Again, that in turn may have a negative impact on quality of life and life expectancy. That said, there are certain conditions that happen more commonly in older adults than younger adults. Geriatric syndromes. So what is a syndrome? A syndrome is a group of signs and or symptoms that occur in the older adult more frequently than they occur in the younger adult. And these signs and symptoms characterize a particular abnormality or condition that occurs more frequently than is likely due to chance alone. And the signs and symptoms can be emotions, and they can be actions. This is a list of several geriatric syndromes. The ones in red are some of the ones that I may present on, or I present on throughout the course of the academic year. So there's delirium, dementia, dizziness, dysphagia, falls, frailty, gait abnormalities, hearing loss, nutritional disorders, urinary incontinence, visual disorders, pressure ulcers, and osteoporosis. And that's just a few of the geriatric syndrome. So why is this relevant? And why is geriatrics relevant? If you look at the population, you look at some of the epidemiology and the statistics, the population is aging. A significant fraction of our population is 65 years or older, and the geriatric sector of the population continues to get old. Sector of the population continues to grow. Okay, it is estimated that about 9 years from now, in 2029, 70 million people will be at least 65 years old, and that's barring stuff that just happened, like the pandemic, the effects of what just happened, like the pandemic, where the sectors of the elderly population died at a disproportionately higher rate than the younger sectors of the population. In 1950, 8% of the world population was 59 years old. So that's 70 years ago, only 8% of the population was 59 years old, was over 59. In 2050, that's about 30 years from now, as much as 21% of the population will be above age 59. So that's almost a threefold increase. In 2010, the number of people above the age 59 was 759 million. This will increase to an estimated 2 billion in another 30 years. Okay, so these are reasons why this topic and geriatric medicine and care of the elderly is important and relevant. In addition to that, the aging body is physiologically different from the younger adult body. Therefore, some of the diagnostic modalities and the treatment interventions that we have, this includes, but it's not limited to, assessment tools, standardized nutrient requirements, and how we prescribe medications, the guidelines. Those guidelines for younger patients, it's different than what's required for older adults. And so what you use for younger patients ought not be generalized to the older adult population. Why is this relevant? Again, even in the US population, this is just summarizing some of what was said before. These are national trends in aging. The US population is also aging. On the y-axis there, the number of people over age 65 in terms of millions. On the x-axis is a year. In 2000, there was somewhere around between 30 and 40 million individuals in the US above the age of 65. In 2020, it's somewhere between 50 and 60 million. The population is aging. So why is this relevant? It's also relevant because we practice evidence-based medicine. We practice an evidence-based standard of care. And what we do, our assessments, our intervention, should translate into an improvement in quality of life and life expectancy. In other words, whatever interventions we do should result in a decrease in morbidity and mortality. And all of this should be guided by the age-friendly framework, the 4 M's framework in geriatrics, right? This is a very important slide. This slide was generated in the context of geriatricians, fellowship trained geriatricians. But nonetheless, I think it applies across the entire healthcare spectrum, and it applies to everyone who's involved in the care of older adults. Geriatrics has an overwhelmed workforce, and it's a critical shortage specialty. And this is even more evident now during the pandemic. And that's part and parcel because, as I just mentioned, older adults died at a disproportionately higher rate during this pandemic than younger adults. And not only that, but prioritizing to address the needs of acutely ill patients, that meant that resources were pulled or healthcare personnel were redeployed from the outpatient setting where they were caring for older adults to prioritize to care for acutely ill hospitalized patients. That means that those resources and those healthcare personnel, those geriatricians, would not have been available to care for the elderly patients in the outpatient setting, or elderly homebound patients, or elderly patients who were in essence ordered to be sheltered in place. And this, can have devastating consequences. Geriatrics has an overwhelmed workforce, and it's a critically shortage specialty. Several years ago, this slide was made several years ago, it was determined that over 17,000 geriatricians are needed to provide adequate care to the elderly patients in our population. That's 17,000. But there were only about 7,500 available. And presently, as we're seeing during this pandemic, presently, we are not prepared to provide adequate care to our geriatrics, the members of our geriatric population. And we're not prepared to satisfy the increase in demand. The demand for geriatric care continues to increase. But what we're seeing is that the number of fellowship trained, board certified physicians seems to be decreasing. Why is that? And there may be certain biases here, but why is that? Why is that? For some reason, geriatric medicine is perceived as an unattractive discipline. There's certain stigmas associated with geriatrics. There's a perception to some degree that it's saturated with elderly, frail patients with chronic medical problems and end-of-life issues. There's a perception that it's not an interventional kind of specialty, therefore there's not much to be done. There's a perception that there's a heavy burden on the physician. It demands a tremendous amount of the physician's time. There's a perception that's a tremendous burden on caregivers and families. So it is viewed as an unattractive specialty, an unattractive discipline. Even the compensation package is not viewed as favorable as some of the other specialties. And there are comments made that the reimbursement rates from Medicare and Medicaid needs to be adjusted to reflect the amount of effort that's put into caring for the older patient, the older adult. So what are some of the principles of the geriatric assessment? Some of the principles of the comprehensive geriatric assessment includes focusing on the older adults with complex medical problems. Of course, again, this is on the guidelines of the 4Ms framework. Focusing on there's a goal to promote health and well-being. There's a goal to promote wellness and independence. There's a emphasis placed on incorporating a multidisciplinary team-based approach, and there's an emphasis placed on functional status and quality of life. And we'll talk about some of the ADLs and so on later. I like this phrase, this question in red. Did I ask? Because it highlights the importance of the history and doing a comprehensive, detailed history. Did I ask? Did I ask? If a comprehensive, detailed history is performed, majority of the times, the right decision can be made to help the patient. The acronym DIDIA stands for Did I Ask? And this is intentional. There's an example of an older adult who has an underlying medical problem, maybe has some underlying degree of cognitive impairment. And this patient, this older adult, for whatever reason, started acting up, whatever acting up means, became agitated, whatever agitated means. A reflex action, and that's one of the reasons why the stop sign is there, to stop ageism, to stop the assumptions, to stop the discrimination, to stop the prejudice. If an assumption is made that that older adult is acting up because the older adult is old, or the older adult is acting up because the older adult has, you know, some degree of cognitive impairment, then again, the healthcare provider may not pursue or may not investigate any potential underlying causes for this change in behavior. Okay, so DIDIA is intentional in that one of the questions being asked is that what is the differential for a change in behavior in a patient with maybe some underlying cognitive impairment? Did I ask the question? Okay, so in a patient who may not be able to express themselves for whatever reason, agitation may be caused by dehydration. Dehydration can cause agitation, but did I ask the question? Infection. Infection can cause a change in behavior. It can cause delirium. Okay, it can cause agitation. Did I ask? Did I pursue? Did I look for a source of infection? D is dehydration. I is infection. What's the other D? Drugs. Drugs. A variety of medications can cause change in behavior. Medications are notorious for having adverse effects. Impaction, the other I is impaction. And the other A is angina, chest pain. Pain in an older adult can cause change in behavior, okay? The other acronym, vitamins. Vitamins is used to, just to guide our differential. Any presenting sign, any presenting symptom can be worked up using the acronym vitamins. V is vascular, I is infectious, T is trauma, A is autoimmune, M is metabolic, I is idiopathic, or I don't know. I could also be iatrogenic. N is neoplastic, and the S stands for substances or drugs, and even pursue underlying psych issues, okay? The 5 I's of geriatrics is highlighted here. We're still under the principles of the geriatric assessment. We should consider, mental capacity. We should consider the intellectual capacity, consider immobility, instability, incontinence, and iatrogenic. In terms of functional status, a good way to assess functional status is to consider the activities of daily living. It could be divided into a couple of categories: self-care, mobility, and instrumental. Okay, self-care has to do with, the patient's ability to take care of themselves as far as bathing, dressing, toileting, and so on. Mobility has to do with the ability to walk from one room to another, to climb stairs, or even walk outside the house. Keep in mind that self-care, transferring from bed to chair, falls under self-care, even though it has to do with mobility. And iatrogenic, instrumental, includes things like the ability to use the telephone, to prepare meals, to manage finances, do the laundry, go shopping. Several factors impact functional status, okay? There are a variety of factors, and it's good to consider them in the assessment. Drugs can do it. Economics can do it. If the patient has limited funds, then the patient might not have access to food, right? Physical barriers, okay? If a patient cannot, ambulate to the bathroom, then that may contribute to incontinence, okay? So there are a variety of factors, medical, that impact functional status. Where can the geriatric assessment be performed? Anywhere, right? It can be done in the outpatient setting. It can be done in the acute care setting. It can also be done in the patient's residence, in a skilled nursing facility, in assisted living, and so on. This is a very this is a very informative slide picture. Can you tell? You can take a minute to brainstorm here. Are there any indications that this patient is at high risk for falls? Are there any indications here? So this is part of the geriatric assessment. I see a hand waving. Any comments? I didn't inquire if there are any comments.
I saw the walker there, so that tells me maybe it's hers, and maybe she needs help walking.
Absolutely. So that's one. I think there are like 12 different factors here. So walking, right? She needs some kind of help assistance walking. Can anyone else point out? So she has a walker there.
And Dr. Prosper, what is that gray thing that's on the table?
Yeah, so that's a good question, right? I'm wondering if that's related to, can you guys see my mouse?
Yes.
Is it related to this? Is there a means of communication?
Yeah.
I don't.
Yeah, the emergency alert
Right.
necklace.
So
So
in
that's-
addition to the walker, that suggests maybe that she has some sort of something to help her monitor her health at home and to maybe send a signal for distress.
Absolutely, right? So this implies that maybe there was a previous episode, right? Something might have happened before, right? And there's a reason for her to have a medic alert bracelet or this device here. Anything else? Do we see anything else?
Her posture and her hands look like she has contractures.
Yes, to some degree, right? And yes, absolutely, her posture and her hands. And what else do we notice on her hands? On the physical exam, Heberdine's and Bouchard's nodes, right? What else do we notice? Do we notice anything here? What is she wearing?
Glasses?
Her glasses? Do we see the spectacles, the glasses?
Yeah.
Yeah, so that may be an indication of visual, right? Vision issues, right? What do we notice here?
Medication?
Medications, right? Now, is there a comment on the floor? What's the floor made of? What's covering the floor? What's this?
Rug?
A rug.
Carpeting, the
Carpet,
carpeting,
right?
yeah.
Another one, right?
Carpeting.
Yeah.
So we may need to reevaluate the living environment, right? And make some adjustments there, right? So she's at risk for falls. But that's
So
a good setting to,
Dr. Prosper, just pointing out that people have been putting some answers to your questions in the chat.
oh, okay, absolutely.
Many of those things that were already mentioned by the other panelists and speakers, but just calling your attention.
Okay, great, great. Anything in the chat that I didn't mention? Anything that was pointed out?
No, I think it was all mentioned. Just
Okay,
I just didn't
great.
want you to think that people weren't answering.
Great. I'm not able to see the chat. Okay,
So we'll call it out for you then. Sorry about that.
thank you. So a comprehensive geriatric assessment can be done at home. And in making an assessment or evaluation, we should evaluate the home environment also, okay? Because it can impact quality of life. It can impact. So the medical assessment, there are several components to it. One major component is the history, right? And the history is of utmost importance, right? And there should be emphasis on factors that impact function. Do not overlook the vision, do not overlook the hearing. Nutrition is important, but what's the point of having nutrition if you cannot eat? Dentition is important, right? Based on history, we can elicit whether or not the patient, has gained or lost weight. Okay, so we can make certain determination from that. We can comment on or elicit information on gait, walking ability, incontinence, drug use, prescription drug use, OTC drug use, okay, herbal drug use, herbal use. The physical is also important, okay? We can get a lot of information from the physical exam. I remember one patient who came to me, had tremendous difficulty hearing, and it was a simple solution. Simple in that you have to do the physical exam, you have to look into the ears, look into the external auditory canal, and you see that it was occluded with wax. Okay, a simple referral to audiology, a simple referral to ENT for evacuation, and the patient was, hearing fine. So you can get a lot of information from the physical exam, and we should take the time to do a comprehensive exam, including cognitive screening, okay? The mini mental status exam. And this is basically commenting on some of what I just said. In terms of financing and how do we pay for care, there are two major ways. The largest insurance plan in America, the Medicare and Medicaid. But it all started some time ago, around 1935, with the enactment of the Social Security Act, okay? And it was a doctor named Dr. Francis Townsend who, you know, who thought it necessary to help the old aged, okay? And so he had a proposal and he presented it under the president, FDR. And one of the things he suggested is that older adults who could not afford to take care of themselves should get a stipend. I'm using the word stipend, but should get maybe some kind of monthly contribution, you know, just to take care of themselves. And so following that, there was the enactment of the Old Age Survivors and Disability Insurance Act, okay? And what that really did was it created a Social Security program, and it created a program for insurance for those who are unemployed, okay? To put things in perspective, the American Geriatric Society was formed about 7 years later. And later on, with some changes, adjustments, modifications, amendments, in 1965, Medicare and Medicaid was put in place. Medicare, you guys are going to get a lot more on this later on in the year. There are more experts who can speak on this. You know, they're more equipped to speak about this than I am. And but in a nutshell, there's Medicare and there's Medicaid. Medicare, I think of Medicare as caring for the elderly, whereas I think caring for the elderly, whereas Medicaid is helping or aiding, you know, those who are financially, you know, indigent, or those who are poor, who need financial assistance. Medicare is federal. It's run by the Centers for Medicare and Medicaid Services. It provides coverage for individuals who are acutely ill, that are above the age of 65 years old, or it provides coverage for those who are disabled, and it provides coverage for those who have end-stage kidney disease. Okay, there are several parts to Medicare. This part A, B, C, and D. Briefly, part A has to do with providing coverage to patients in the hospital setting. These are all fee-for-service, right? A service is provided, and the sector that's providing the service gets compensated for it. So it's fee-for-service, gets paid for it. Part A provides coverage, insurance coverage to hospitals, nursing facilities, hospice and home health services, these services that were provided to the older adult. So it provides compensation for those services. Part B provides payments to the social workers and so on. You can read it there. Rehab therapists, psychologists, and so on, labs. Okay, there's part C, which is quite complicated. And there's part D, which to some degree is also complicated. Part D has to do with coverage for prescription medications. And part C has to do with, it provides coverage for the same as A and B. However, health maintenance organizations, managed care organizations, they spearhead these things, okay? More to come in the future. One of the things to highlight in the Part D coverage for prescription medications is that usually the patients have a deductible, and the insurance covers a significant fraction of the rest, as much as 75%. If the patient uses up all the insurance coverage, they may hit a limit called, once they've reached the limit, they may hit something called a donut hole, whereby they're responsible for all the coverage. This is a little more complicated than I'm explaining, my apologies, but more of this to come in the future. Okay, but we definitely need to have a more extensive talk on Medicare and Medicaid later on. Any questions so far? Okay, medical ethics. And I just want to highlight some of the key terms and some of the guiding principles of medical ethics. This is mainly medical ethics in the United States. Okay, and some of our guiding principles are the term autonomy, non-maleficence, I struggle with pronouncing that word, beneficence, justice, and I added the last bullet, which has to do with teaching, okay? Autonomy has to do with respecting a patient's right to dictate what happens to his or her body. And I would like to emphasize again, because we're dealing with the geriatric population, all of this should be happening under the guidance of the age-friendly framework, the 4Ms framework, okay? So respecting patients' autonomy, even in the context of an informed consent, okay? The patient has a right to know the options available, including the option to do nothing and including the option to refuse care. Okay, so autonomy has to do with respecting the patient's ability and right to dictate what happens to his or her body. Non-maleficence has to do with, some say malfeasance, non-maleficence has to do with not simply doing no harm, but specifically do not intend to do harm. Beneficence has to do with, again, not simply doing good, but maximizing good. And I'm making those distinctions to say there are risks and benefits involved in every decision, right? In every intervention, there are risk and benefit. Take for instance, drawing blood. Drawing blood may be a reflex procedure in a patient who's admitted to the hospital or even an outpatient setting, okay? But drawing blood has its risks. An instrument, a needle is introduced to the skin and it perforates, it penetrates the skin. There's pain associated with that. There's an increased risk of infection, albeit small, but there is an increased risk of infection. There's an increased risk of bleeding, and depending on where the blood is drawn from, there's an increased risk of perforation and other things, hematoma, okay? So there are risks involved, but beneficence has to do with maximizing the good and minimizing the bad, okay? Justice is a very tough term. I'm not sure if I have a clear-cut consensus on exactly what it means. However, in the context of healthcare, is healthcare a right versus is it a market good? And is it standardized? There's inequity throughout based on age, based on race. There's evidence, there's data to support that there's tremendous disparity in the level of care that's offered to individuals based on race, based on age, based on gender, and so on. Okay, so is healthcare a right or is it a market good? And with technology, is everyone offered the same level of treatment?
Dr. P, you have one question.
Yes.
I don't know if you wanted to field them as they came in.
And I'll make the last comment in terms of teaching is that we have a responsibility to pass on the knowledge that we've learned to the next generation in order to continue to provide good quality care to our patients. What's the question?
From Dr. Emmanuel.
Mm-hmm.
Hello, Dr. P. This is the question of, at what age should an elderly person start seeing a geriatrician? Because some 65-year-olds regard themselves as young and see it as a stigma when they're seeing a geriatrician rather than a regular quote-unquote primary care doc.
So that is a great question, right? And I think efforts should be made towards removing the stigma because geriatric medicine is a great field. It's a great specialty. And we do great work providing great care to great patients, right? So efforts need to be put in place to remove the stigma from geriatric care and geriatric medicine. That said, to answer your question more directly, there is chronological age, we understand that, and then there's physiologic age, right? So am I using an age criteria? Most age criteria go by 65. Okay. A lot of generalists who are not specialists in geriatrics are providing geriatric care. Are they as equipped to do that? The geriatrician is trained in such a way that attention is placed at investigating, at looking for, at deciphering underlying or conditions or syndromes that are more prevalent in the elderly that may not be picked up by the generalists or others. So at what age? I'm not answering it. I mentioned 65. But most certainly there is a need for generalists. And even if you are young at heart and vibrant and energetic, and you know, there may still be some benefit from pursuing care with a geriatrician, because again, the geriatrician may pursue things that may be missed by the ordinary, I don't want to say ordinary, bad choice of word, by the generalist. But 65 is a number that's usually used for benefits, for example, for Medicare. Any other questions?
Dr. Emmanuel says thank you, but there are no other questions currently.
Let me just mention a quick example that was given in terms of beneficence. One of the examples that was given has to do with Jehovah Witnesses and their position on blood transfusions, and we ought to respect their position on not being willing to, on not wanting to be transfused. And I'm stating this example by saying that a physician may see a benefit in a particular patient who is hypotensive, meaning has low blood pressure, a certain patient who is severely anemic. A physician may see the benefit in doing a blood transfusion in that patient in terms of saving the life, okay? In terms of preventing death and in terms of just helping the patient. But that is not in alignment with the patient's goals of care. And transfusing that particular patient may do more harm than good. More harm from a spiritual level, more harm from a family level, more harm from a social level, more harm from a physical level, okay? And therefore, it is good to respect the patient's autonomy and honor the patient's wishes and not give the transfusion. And that's one example, okay? I hear no more questions. So
There are
thank
no
you.
open questions.
So thank you very much.